What's this guy called? Tiny?
Tiny, but he doesn't need to track you if you don't want him to.
I'll try to stay. I'll try to stay. Thing. How about a clicker?
I
To
had
advance.
one, I didn't set it up yet, but I can be your clicker.
Do we? Okay.
I can be your human clicker.
All right. So I'm gonna have to stand a little closer here so I don't put my head in the view. That'll work, right?
Back up just a little bit.
Yeah, because you
Mine,
be on
yeah.
camera. Okay.
I
All
can.
right. Apparently, I'm gonna have to stand like this the whole time. So should be all right.
All right, good evening, everybody. Thank you for being here with us. I'm Ann Valvoto with the Dental Lab. And tonight, our team at the Dental Lab was talking about what do doctors, what can we bring to your patients to help them through you? And what kind of education, what's missing out there in the dental space that we can bring to you from not only a lab perspective, but a solution perspective and a clinical side of it, and just bring it all together to really help support patients. So tonight we are bringing Vince Lancinese from Nexus iOS, and then Dr. Scott DeRossi is going to be joining us virtually with Nexus Dental Systems to talk about how to maximize Medicare and billing solutions for patients usually are underserved and patients that can't really get the best benefits out of what they should have access to, which I'm sure you all understand what I'm trying to say. So thank you for being here. I'm going to turn it over to Vince at this point, and I'm going to be his human clicker. But if you need anything, anybody from our team can help you out.
Okay. Thanks, Ann.
Yeah.
All right. Just a few housekeeping things. It is pure coincidence that our solution is known as Nexus iOS and that our second speaker is Nexus Dental. Okay, we are not affiliated in any way. Okay, it does go well together, so we got to thank Ann and Jay for putting us together. We are, give me one click. Okay. Okay. Give me a second click.
Sure.
Okay. The parent company that I work for is Keystone Dental Group. Some of you guys may have heard of us, maybe you haven't. The subsidiary company based out of Melbourne, Australia, is known as Osteon Medical. That's technically my employer, is Osteon Medical. Okay. And the solution is known as Nexus iOS. So a lot of people go, well, wait a minute, what's this name or what's that, or you're this here and I want to draw those distinctions because you do not have to use Keystone implants in order to use Nexus iOS. Okay, so if you're used to using a certain system, you're comfortable with a certain system, the only requirement that I have for you is that it has to have a universal multi-unit abutment. Okay, our solution is based on a multi-unit abutment for every solution that you're about to see. Let's go ahead and advance.
Yes, sir.
Okay, give me a double click there.
Yes, sir.
Okay, so a lot of competition out there in the digital space right now. I keep walking past my camera.
You're fine.
Stay here by the camera. A lot of stuff going on out there. Some of you may have used OptiSplint. Some of you may have been exposed to what they call photogrammetry. There's another term out there, grammetry. And there's every day there just seems to be something new on the market, okay? And that's okay. That's the way technology works, and it's coming at us at a fast pace. But just to differentiate, we are 100% digital. In other words, no looting of anything in the mouth, no verification jigs, very simple, very accurate, very fast, okay? Typical, if you think of conventional therapies, you're looking at 6, 7, maybe even 8 appointments. We're down to 3. And technically you could make it 2, but I don't recommend that, okay? I'm going to move you along.
Go for it.
Okay. And from your perspective, it's literally just scanning, uploading your data to the folks here at the dental lab, and voila, your prosthetics show up at your doorstep. I mean, it's that simple. And we're going to talk about the science behind that a little bit. We'll talk about the compatibility a little bit, and we'll talk about what you have to do in order to do that. Right. So, as I mentioned, any company that makes a universal multi-unit abutment, okay, looks a lot like a Neodent multi-unit abutment, looks a lot like a Straumann multi-unit abutment, Nobel, Keystone. I mean, there's a lot of us that have them, okay, as you can see here. The great thing too is there's other companies that are available that can get you a universal multi-unit abutment for even an implant that you might be using that doesn't have one themselves, okay? So there are solutions, okay? Who has an intraoral scanner? Okay? You'd be happy to know that all these are validated for our system as well. In fact, if you take a look at this brochure, this is the list of validated scanners we have available. Now, I don't expect you to be able to see all of them, but you can see there's a lot of wands around this kit, okay? All right, so how does it all work? Well, it really works with this kit right here, okay? The Nexus iOS scan gauge kit, which will be supplied by the dental lab for you to borrow. So you don't have to buy your own kit, okay? Not to get into too much minutia about the kit, but I just want to point out, you can see that it has 18 different scan gauges. We call them gauges simply because they are horizontal scan bodies, okay? And in order to differentiate it from normal scan bodies, we just call them gauges, okay? Some people like to call them battleships because they remind them of the old game. Some people refer to them as flags. It doesn't matter, okay? But what does matter is the science that actually was implied or implemented through this technology. As simple as these gauges look, there's a whole lot of science behind it, okay? They're all titanium alloy, so they're very durable. They're autoclavable, okay? They're reusable. You don't have to throw them out after 5 cases or whatever. They just get used over and over again, okay? So there's 18 scan gauges, and I'll talk about the difference between them all shortly. As well as some other components in the middle of the kit, called scan analogs and narrow scan bodies, and I'll identify those shortly. But you can see there's 3 different lengths and 2 different cuff heights. So depending on the depth of your transmucosal abutment, your multi-unit abutment, you know, I might need the height to come up and out of the tissue, okay? From your perspective, it's just scanning in the Z-axis, okay? Because when you look straight down on top of that scan gauge, you can see all 7 sides, all 7 facets, okay? And if you can't, let me color code it for you. Now you can see all 7 sides, okay? I don't have to make big moves with my wand to get this information. I am just literally moving over, passing over the top of it, moving to the next one, and so forth, okay? Okay, some of the science, some of the nerdy stuff that goes behind it. Okay, 1, they're all milled, custom milled. And in addition to that, we go ahead and scan them ourselves. Okay, now why do we do this? All right, so everybody's familiar with traditional vertical scan bodies. Okay, there's, I don't know, hundreds of thousands of the actual physical scan bodies that are out in the world today, maybe even 1 million. But there's one singular digital file for all of those components. Okay. Has anybody ever heard the term acceptable tolerance in manufacturing? Okay. What that means is when you make something, there's an acceptable range that still passes. Might be a little small, might be a little big, but as long as it's within range, it's considered passable, and it goes into production and moves into this workspace. Okay. But the problem is the digital file never changes. So there's a discrepancy. Your physical object, in this case, a scan gauge, could be different than the actual digital file. Okay. That leads to a coefficient of error. That's an error. Now, when you're doing a single implant case, or maybe even a 2-unit bridge, the error is not significant enough to worry about. But when you're doing full arch and you're doing 4, 5, 6, 7, 8, I even did a case with 10 implants, and you have to compound that. Now, if anybody remembers from math, you know, or their science classes, right? You used to compound the coefficient of error of an equation by multiplying this error by that error, by that one, and as you got around the arch, you didn't have anything accurate at all. Okay, so every single one of our scan gauges is scanned individually, and it has its own digital file. So if this one, I guess I got to point to it on the cursor here, right, for our audience, right? If this one happens to be 3 microns small, so is the DME, so is the digital file, okay? And so on and so forth, okay? So again, when we look at the kit, I would show it on camera,
Mhm.
okay? Every kit has its own individual number and has its own folder of 18 digital files, okay? So we've eliminated that inaccuracy across the board. Okay, so again, there's another view of the kit. You can see we have on the right side or on the left side of the kit is your 3mm cuff, and then on the other side is the file. Okay. Okay, I'm gonna hold off for that. Oh, I'll explain the other components when we get into the workflow of what you have to do. All right. So you've decided that you're going to do this. Okay. Zach or one of the guys in the back are going to show up. They're going to bring their kit with them. Okay. You're going to use your scanner, right? Nobody has to buy a $36,000 camera, right? If you're familiar with PIC, I think it's 36. It might even be 46,000, right? Okay. And even the lesser expensive one is Shining 3D,
Mhm.
and that's 22,000. Okay. You don't have to buy any of that. You use your existing intraoral scanner, you use your Nexus kit that you're borrowing from the dental lab, and voila, you're in business. Okay. We're going to start with a couple photos. Okay. Repose, full face retracted, full face smile. Very simple. Don't even need one of the big fancy cameras that all the young dental students have, right? With the little wings that come out like this and everything. We don't need any of that. Pick up your iPhone, take a snapshot. Okay. Very simple. All right. From there, we're going to use our intraoral scanner, and these are all scans that you guys know how to do, and in many cases, your assistants know how to do. Okay, it's not uncommon for us to actually delegate this to the assistants. Why? Because they're usually better scanners than we are anyway. Okay, so we're going to start by scanning the upper, the lower, the bite. Okay, so in this particular hypothetical, the patient is presenting with a fixed provisional prosthesis. The implants have already been healed. And the lower is natural dentition. Okay. So again, we're going to scan the upper, the lower, and the bite. We do that every day with every patient, right? From there, we're going to remove the prosthesis. And within the kit, again, I mentioned that there's narrow scan bodies and there's what we call scan analogs. So we are going to attach the 3 narrow scan bodies that are in the kit to 3 of the sites in the patient's mouth, and we're going to do a tissue scan. Okay. Then we're going to take the scan analogs and we're going to attach those to the intaglio of the provisional prosthesis using the same screws that was holding the prosthesis in. And we're going to extraorally scan that 360 degrees. Then we're going to use our scan gauges. You'll notice it almost looks like a little Tetris game. Okay. Now this is the big advantage to having a horizontal scan gauge. It's why we have the only company with FDA clearance and a patent on horizontal scan gauges. Because scanners are notoriously flawed when you scan soft tissue. And with 2 vertical scan bodies, I have a big soft tissue space in between. But let's compound it. Coefficient of error between those 2 implants, between those 2 implants, between those 2 implants. Till I add it all up, I don't have an accurate system. We decided to lay the scan gauges on their side, thus eliminating any tissue gaps whatsoever. We've eliminated that error completely. Okay, we're going to do 2 quick scans. We're going to go linear from left to right, and we'll do a separate scan in a separate window from right to left. Okay, it's about an hour appointment. That's it. I don't know if this will play for us. We might just have to help it along. Did I get it? I think I got it. Okay, this is just going to show you real quick scanning. It's real simple. All right, they get to see that on the screen, right?
Correct, yeah.
Okay.
The same view up here.
Upper, lower, bite. Again, you do it every day. Okay, it's actually going to, from a schematic standpoint, you can see on the left-hand column, it's listing out our scans. Okay. Scan gauges, see how they're all oriented so they're close to each other but not touching. 1 linear scan, followed by a second linear scan in the opposite direction. our soft tissue scan. And then our extra oral showing the scan analogs, the extra oral 360 scan of the prosthesis.
Hey, Vince.
Yeah.
How are you scanning the light scan if there is no edentulous?
Do they have a denture?
Okay, so that.
Okay. And if a patient presents edentulous with no denture, then that's the first thing that we're going to do is we're going to take the necessary steps to get them, even if it's a ill-fitting, terrible denture. Okay. We just need to have something to establish the vertical. Okay.
Quick question.
Yeah.
Yeah, but most of the periodontist and oral surgeons, when they put these in, you obviously put them on, they're conical themselves, so they don't even have hexes. So how do you decide where you're gonna put that horizontal button? In other words, what angle you're gonna put it on?
Okay. That's a great question.
Vince, do you mind rephrasing that just so that virtually, in case they couldn't hear that, they can hear it?
Rephrasing his
Dr.
question.
Turner's question, yeah.
So Dr. Turner was asking, you know, because multi-unit abutments are typically just a cone on top, how do we engage the scan gauges if they're not indexed?
Not how you engage it, but how do you decide what angle you wanna put it on to capture the scan does? 'Cause I
Okay.
saw them, one was going this way, one was going that way, that kind of thing.
All right. I didn't want to get into that minutia, but you asked, so let's go. Okay? It's okay. It's actually okay. It's a good question. All right, so if you'll notice, the two distal sites are coming forward. They're coming mesial, right? The extension goes, and I can't have to show that. The extension goes that way, right? Okay? When you're scanning the gauges, you have to capture all the gauge itself. Okay? So if I start with the distals and I start putting that long arm distal, I have to take my wand and go pretty deep into the mouth. Okay? So bring the distal ones forward, typically a little bit palatal, and then we start to crisscross in the front. But aside from that, it's 100% random. There is going to be an infinite number of patterns that you can come up with. Okay, because there's 3 different length gauges available, as well as the different collar heights. So, and it's funny because almost anybody who does their first case is trying to be so meticulous, and that's probably my fault because I'm like, you know, this is the most important part of the whole thing, which it is, because it's those 2 scans right there that determine the fit of your prosthetic to the abutments. Okay, everything else you're doing is for the aesthetic outcome, which I realize is important because that's what the patients come for, right? They come for teeth, they didn't come for implants. Okay. But we need this thing to passively seat. So this becomes the critical step. Yeah.
Just going based off of that, do you have to worry about them rotating at all?
No, because once you hand tighten your prosthetic screw, it's not going to rotate. Okay. We showed that video already. Okay. The only thing that I want to identify on this slide, okay, is what we call the Nexus analyzer. Okay, so you'll have access on our website. We call it the validation software. But you're going to be able to take those 2 scan gauge scans and superimpose them in the analyzer, and it's going to tell you within seconds whether you have a successful match or you have to rescan. Why is that nice? Well, one, it's not an extra appointment. I don't have to wait for a verification jig where I have to section it and lute it back together. Okay. The scan gauges are still in the patient's mouth and the patient is still in the chair. Within real time, we're going to know whether we're going to fit, you know, pass the Sheffield test. Are we familiar with that? That's that fancy one where you put a screw in on one side of the prosthesis and you check the other side if it bounces at all. That's called the Sheffield test. Okay. That's considered sub 20 microns. Sub 20 microns. Right? Does anybody realize how small that is? What's the average thickness of a human hair?
17.
No, it's 50 to 80.
Yeah,
If I say it really fast, maybe you'll believe it. Yeah, it's between 50 and 80. Yeah, and we're talking sub 20 microns. It's kind of crazy how digital's getting. Okay, but again, all we're looking for now, I know you guys, because I work with you, I've done it for many, many years. All right, there's also gonna be a ring. I don't know if you guys can see that on the screen right here, okay? The word success is in the middle, okay? Now, if you don't get success, it won't be a green ring. It'll be a red or an orange ring to tell you kind of how, how off you are, all right? But the ring goes all the way around. Now, if it goes all the way around 100%, then you're like, hey, I scored 100, right? If you get to about 75 or 80, it's still gonna tell you success. So don't get too down on yourself. All we want to see is success, okay? Because there's no tangible difference. There's no clinical difference between 20 microns and 10 microns. Other than bragging rights. And I got 10 microns, what did you get? It doesn't matter, okay? We want to see success. If we don't, again, the patient's still there, we can get a couple more scans. The scans are only like 40 seconds, right? So if we have to take 2 more scans, what do we lose? An hour, a minute and a half? Okay. So anyway, I belabored that enough. Okay. So to recap, all right. Now this is something that can be done on dual arch as well. So you can see here, all your schematic on the left is showing what would happen if I was doing both arches simultaneously. And then listed out here is a single arch. It's 2 photos, 7 scans. And of course, if you're doing both arches, it's, if I cover this up, maybe you guys, it's 2 photos and how many scans? If that's 2 and 7, what would this be? 2 and what? Nah, it's 11. It's because you don't have to do the upper lower bite twice. Okay, we call those the foundation scans. The upper lower bite are the foundation scans. Everything we do starts there. Okay, and in the latter part of my presentation, I'm going to talk about the immediate protocol. We can use this technology to get to that provisional prosthesis too. No longer chairside conversions. We don't have to pick up anything in the mouth or convert the denture and everything else. We can literally take a few scans, move it to the laboratory, and they'll have a prosthesis for you later today, or most likely you'll deliver it tomorrow. Okay. Okay, some of the options. Well, I'm not going to go into a whole lot of detail with this because I want you guys to understand that all the options that you're used to are still going to be available through the dental lab. Okay. We have what we call the Nexus hybrid. Okay. Obviously a hybrid is like an FP3, right? You notice a bunch of pink. It's a bad schematic, but the Nexus bridge is more like an FP1, right? You have adaptation with a lot of soft tissue and you need the ovate pontics, right? We can do that. Okay. We can do more of an economical. This is more what you may have seen like a traditional wraparound. Okay. Still has a titanium substructure, but it's milled PMMA. Okay. So it's still very, very strong. There's just flowable acrylic to seal off the intaglio. And then there's a removable option as well. Not overdenture. This is definitely not an overdenture. Okay. This is completely 100% implant supported as well as implant retained. But for those patients that might need a ridge lap or maybe need a little bit of lip support, or God forbid you get a case back that they didn't realize where the smile line was, and so it's going to show a transition line, it's an alternative. Okay.
Vince, Dr. Corral wants to know, what if you don't love the occlusion and or aesthetics of your temp prosthesis? Still scan and modify later possible?
Yes. Oh, what a great question. Okay. First of all, I think it's important. I'm even going to look right in the camera. Okay. I think it's important to note that when you take your foundation scans, even if it's a provisional that you're not happy with, we're just trying to capture where you are today. Okay. In conjunction with the lab here, we're going to come up with a new smile design that better fits that patient. Okay. And it's going to go through you for approval before we proceed. Okay. And the nice thing about it too is it doesn't matter what type of prosthetic you need. Okay. And I should have a picture here, but I don't. But if you like full contoured zirconia, that's an option as well. Okay. And we can do full contoured zirconia direct to MUA now. A lot of people are doing that now.
She said awesome
Relating
things.
to that doctor's question, what if you needed to open the VDO a little bit? How would you do that?
You would tell us that, or tell these guys, because they're doing in some cases, they'll do the design. Sometimes we'll do the design. Tell us how much you want it open. Okay. this gets into that third appointment, and I'll explain that momentarily, okay? But that's a very valid question. Okay, so what's going to happen within a couple days, you're going to get an HTML file with your new case design, right? Your new smile design. The turquoise represents the what we've got captured on the foundation scans. So in that case, it might be wrong. And in the Denton color, it's going to be the new design. Okay. And from here, anything and everything can still be changed, right? So if you look at this and you love it, you're going to approve it and you're going to move on. If you want to tweak a few things, you'll just tell us to tweak a few things and we can move on. Or if it's really off, you'll tell us what to change. We change it and we send you a new HTML file. Okay. So nobody's forced to take anything or accept anything they don't want.
Okay, I'm gonna interrupt you one more time.
Yeah.
Ask about the 2 screw sizes on the MUAs for most implants, I believe 0.16 or 0.18.
Okay, I'm not sure I understand the question there. Point. Screw sizes. Okay. I'm assuming she's referring to the prosthetic screws, which is actually like a 1.4
She says
millimeter.
yes.
Huh?
Yes.
Okay, 1.4 or 1.6, right? So really, there's only 2 systems out there that still use a 1.6 Straumann. Gosh, I think Zimmer, but I'll have to check on that one. Okay. Pretty much everybody uses a 1.4, which is like the Nobel compatible one. But in this situation, if you have a patient presenting with a fixed provisional, the pros screws you're going to use for your gauges are the ones that are holding the prosthesis in place. Okay, you can reuse those and then give them back to the patient when you put the prosthesis back in. Okay, typically, if you need to have extra screws on hand, my recommendation is get the screws from the implant manufacturer that was used. That way you always have not only the right size screw, but most importantly, you have the right screwdriver. Okay, because for some reason, all the implant companies, and I realize I actually work for one, have to come up with a new mousetrap and it's a new screwdriver. And so you got a star, you got a square, you got a hex, you got a little Torx ball, and everybody gets confused. So the easiest thing to do is stick with the system that you have, and you'll always have the right driver and the right length screw.
She says, so both size prosthesis screws will hold the scan gauges. Sounds unique.
Yes, they will.
Okay.
Okay. Okay. So again, this HTML file, we superimpose the photos that you've provided for us so that you can see again where the temporary design was versus the final, and then you can see it overlaid. Again, nobody has to move past this step until you're ready. So it's literally, and I think I have a slide that'll come up. Okay, there you can see the overlay of the bar underneath. Okay, but literally, this is what you get, right? So after you've done the review, you got 3 choices. I love it. Don't make any changes. Green button. Okay. I'd like to see this minor tweak, but let's move on to the next phase. I click the yellow or orange as it looks on my screen. Okay. And of course, if you want to stay in this phase because you're just not comfortable with what you see, you click the red. We come up with the changes for you and we give you a new HTML file for your review. Okay, so nobody's forced to move along until you want to move along. Okay, and the nice thing about this digital review is the patient's not in the chair. Okay, so once you do approve to move to the next phase, and this is where this becomes optional. Okay, we do a try-in. Okay, the lab will print this for you. Okay, it is a prototype of the occlusal scheme. Okay, it is not for sectioning and luting back together. Yes, that did happen to me once. And I yelled at the doctor and I said, I'm sending you another one. Don't cut this one. I said that you were supposed to check to see if the occlusal scheme was good. He goes, oh, the occlusion was perfect. I said, let's move on. Okay. The whole purpose of this try-in is just for the occlusion. All right. If we've changed the VDO, did we change it correctly? Okay. Are we off a little bit, or there's some open spots here or there? You can make the modifications. It's made out of a softer plastic, like a try-in resin. Okay. So it's easily preppable as necessary. Okay. you're gonna have three choices, right? If I make no changes, I'm just gonna go back into the system, I'm gonna approve it with the green button, and we're moving to production. If I make some minimal changes, I wanna click the yellow button, but more importantly, I wanna get out my scanner and I wanna scan the upper, lower, and byte relationship so that those changes can be applied to the final, okay? We don't want you to take a power tool to your final prosthesis, okay? It's not good. It's not good for zirconia, and it's really not good for the PMMA, in my opinion, either, because you're taking the staining and the glazing off, which can affect shading, but more importantly, can cause a little bit more, buildup. Okay, so the try-in phase is great for getting the occlusion perfect, okay? Now, if it's grossly off, maybe the vertical is too high, we kind of guessed and we went too high. So let's make the necessary changes. We can always click the red button and get a new try-in made. Okay, you can stay in the try-in phase. It doesn't mean an additional appointment, but we can stay in the try-in phase until you're comfortable, okay? Most people have minor occlusal adjustments. You just do a quick upper, lower, and bite scan, send it off, and these guys are in production already, okay? So just a couple of examples, okay? You can see the first patient, Rabbi Whittam, he has more of like an FP1 or an FP2 style. You can see it's minimal pink, got more like an ovate pontic design on the intaglio. But he was an upper and lower case. Patrick on the bottom is more traditional FP3. You can see where the pink is going to be in here is quite large, okay? Because he had some larger plastics done when he first got his implants. But these try-ins came out of the box, screwed into the patient's mouth, they bit down, and this is what came out, okay? A good 3 out of 10 times, you'll have zero occlusal adjustment, okay? 6 out of 10 times, you'll have minor occlusal adjustment, and I'm sorry to say, every once in a while, we have that one kind of problem, but we can fix it and get you a new try-in and can resolve it. By the way, as I said before, you simply are going to choose the green button, the orange button, or the red button, okay? Any questions on this side?
No.
Okay.
Thank you.
Okay, so this is just an example of a guy who got definitive prosthetics. I personally hate the gingiva on it. Somebody asked for dark, but that was inappropriate for him, but hey, it's there, it's there.
Zirconia, right?
Yes, these are zirconia, okay? But these can be done in layered zirconia pucks with facial cutbacks for veneering, if you really have the high-end aesthetics necessary. Most of us are finding that monolithic zirconia is gorgeous. It's beautiful. I got a couple examples up here if you want to take a look. And if you have patients that need something that's a little bit, maybe a little bit more cost effective, or here's my favorite. Some people don't like to do zirconia against zirconia. Okay, so maybe you do PMMA for the lower and zirconia for the top.
Like a dishwasher.
Incidentally, I'm just going to jump ahead here as we move along. Okay, those lead times are probably a little misleading because I know you guys here at the dental lab are going to do a much better job. We talked about the materials, right? So if you do get a titanium substructure, it's a 6-4 titanium alloy. Okay, it's what all your screws are made out of. All your, some companies still make implants with commercially pure titanium. But a lot are going to this grade 5 titanium, which is actually an alloy. It's extremely strong. It's got a lifetime warranty on it. Okay. And then other choices are, PMMA or the zirconia, as we talked about. Yep. Take the box too. Okay. Let me just identify a few things before you go. Okay. So here is a milled PMMA provisional. It has tie bases in it, okay? That's an option, okay? This happens to be a printed provisional direct to MUA, okay? It uses slightly different screws, okay? Just so you have those as examples. And this is like a half bar, but you can see the others there. Thank you. Thank you, thank you. Okay, keep an eye on time. All right, I'm gonna just move quickly ahead, okay? Couple of things that I want to point out, and I think this is so big, and I think you guys in the back are gonna really appreciate this too. If you do one of our titanium bars, I no longer need 12 to 15 millimeters of vertical space. I need 6 from the top of the implant, or beg your pardon, from the top of the prosthetic table of the abutment. 6. Why is that nice? Well, we don't have to whack away all the bone anymore. In many cases, we just have to reduce a little bit to get a flat ridge, and we're good to go. We can preserve patient's anatomy a lot longer now, okay? You know, or if the patient presents and they have a collapsed bite, but they want to keep that collapsed bite, and suddenly we don't have 12 to 15. Maybe they don't have enough bone to reduce and still get implants in. Now we don't need to reduce anything. Okay, so this is what we call the hybrid. You'll notice the pink on it, so it's more like your FP3. Just like Patrick's case. You can see these were his finals. They came out of the box, they went in, and he bit down, and that was his occlusion. Okay. If it's more like an FP1 or an FP2 style, where we have minimal pink, notice it's still 6 millimeters of vertical dimension. We don't have to take all this material away or all this anatomy away from patients anymore. And that was Rabbi Whittam's case. Now, I warned the prosthodontist that he was going to chatter. And he said, no, I can't do it. He already agreed that he wanted zirconia. First thing out of the man's mouth was, yeah. Everybody's happy now, okay? This technology can be used for short span bridges as well, okay? Same vertical dimension, 6 millimeters, okay? You can see we can do anywhere from 2 to 6 units. The nice thing about all of this is everything that we talked about as far as what you do in the office is exactly the same. None of it changes, okay? None of it changes. All right, just in the essence of time. This is a busy slide, so I'm going to save you a little bit of time on that. All right, so everybody's got a folder in front of them. Everything I'm claiming on this slide is in these publications on the right side. Okay. And on the left side, you have just a little flyer about the validation software. And what I really find useful is this full arch planning checklist. Kind of takes you through so we know ahead of time what you're going to need and everything else. Okay. You're going to find that there are going to be an infinite number of variables that patients present with. Don't panic. We just might have to tweak our protocol a little bit. Okay. All right, moving along. All right, I just want to point out the removable. Okay, the removable is actually telescoping titanium frames. Okay, so you can see there's 2 frames. One obviously splints the implants and the abutments together. The other one is luted into the prosthesis, and we usually have locators or possibly a vario clip in the anterior to hold that together. Okay, that one, even with the extra material, is only 7 millimeters. Now, if it's full contoured zirconia you want, we still need to maintain a 10 millimeter limitation. Okay, so it's still better than the 12 to 15, but it's 10. Okay, so I love this picture. Okay, here's a gentleman that he needed the lip support. Okay, we weren't worried about a transition line, but he needed the lip support. And he was concerned about his hygiene, so he needed to, because he didn't have the manual dexterity that he felt he would need with floss and everything else. So he wanted something he could take out and clean. But look at that. Beautiful support, lip support, beautiful reveal, right? Snapped in, he bit down, that was it. Okay. Just to review though, what to expect. And this timeline is going to, because I think you guys are going to be able to move it along faster than we could. Okay. But you can see we're in weeks, right? Weeks 4 and 5 is when you can expect your case to be sent out to you. Depending on how quickly you approve, how many times we have to see the patient for the try-in, but in a real cookie cutter way, by week 6, you'll have your prosthesis. Okay, now I'm gonna jump ahead just because I know we have another part to go. So I'm just gonna show this immediate case. Here's a young man that presented, as you can see, failing dentition. He's edentulous in a couple spaces. You know, his vertical's off, you know, his bite's off, but that doesn't matter, okay? 2 weeks prior to surgery, we're gonna get our 3 photos and we're gonna do our upper, lower, and bite scans, okay? From there, we're gonna move into a smile design, trying to correct all the stuff that was currently wrong in his mouth. Sorry, I jumped the gun on that one. Okay, and you'll have this to review, and if you're happy with it, then we're ready to go to surgery. Okay, now for those that aren't doing their own implants, obviously we'll do this in conjunction with our specialist, but it could all be collaborated together. Okay, so literally, we're going to place a few implants. You can see here that we have a couple teeth still here. We have implants in place, multi-unit abutments in place, and a couple of scan gauges. We call this a mid-gauge scan, probably better named a mid-surgery scan, okay? It's real quick. It's about a 45-second scan, and then we finish surgery, okay? As you can see here, the remaining teeth were removed, the remaining implants were placed. Post-surgery, we're gonna scan the soft tissue. We're gonna do a soft tissue scan, okay? And then we're gonna do our left to right and right to left scan gauge scans, just as I explained earlier. And that's it, the patient's going home, okay? You're moving about your day. Those records are gonna come to the lab. The lab is then going to build the bottom of your prosthesis, right? Because the smile design was already approved by you. So we just had to build the bottom, okay? From there, you can go into the printer, you can go into the milling machine, depending on how you guys want it. And you're going to get a prosthesis back out of it, okay? This won't happen to be done with tie bases, but again, it can be done direct to MUA. And so you can see that's his his provisional prosthesis in place. And that's where he started, and that's when he went.
What was the vertical scan body for that he used in that scan?
Ah, good question. Okay. In one of our first, let me just go back. This is the one you meant right here. Okay, so in one of our first iterations of the kit, that was the narrow scan body, right? As I pointed out in the kit, we have our scan gauges on the left and the right, and in the middle, we had our scan analogs for the prosthesis scan, and we have the narrow scan bodies for the tissue scan, okay? But in this particular instance, and I'm just going to jump ahead for a second because I want you to see the pan. The periodontist put these 2 implants really close together. And we literally couldn't get 2 scan gauges side by side. So in that situation, you use one of those narrow scan bodies to give you the extra space. Okay. All right, so if I jump back and show you the scan gauge scan. Okay, notice small gaps between them, nothing's touching, these got close, and obviously those are the 2 that were really close together, okay? But they're laid out, you know, now would I have laid it out this way? Probably not, but this is how the doctor did it and it worked, so that's all good, okay? Left to right, right to left scan.
Is it a problem if they are touching?
Yeah, the analyzer will give you a
Okay.
fail,
All right.
yeah. So you'll want them close. You can take a probe, right? Because they're non-engaging. This is something you mentioned earlier. So so as you tighten the screw down, sometimes the thing wants to turn with you. Okay,
Yeah.
that's not so bad, but you don't want it turning into another gauge. So I'll have you put a probe in there. Let this thing come over, hit the probe. Once it's tight, take the probe out, and you got a perfect 1 millimeter gap between.
Now, as for his final prosthesis, don't you have to have some sort of scan body in every single implant?
Yeah, and he does here too.
He does, okay, so.
1, 2, 3, 4,
For
5.
edentulous sites at 8 and 9,
No, he didn't put it, he
he
didn't,
didn't put any
No.
implants in. Okay, I got it.
nope. And you can even see it over here. There's nothing here, there's nothing here.
Okay.
These are the 2 that were really close together. You got 2 back there and you had 1 disc.
So it's okay to have that middle one's a traditional scan line, right?
Right, because we had the 2 implants were too close
Yeah.
together.
Okay.
So yes, you can use one of those in the middle of the run if necessary. Okay, I don't prefer it, but if you need it, you use it. Okay?
Is there a good place to bring everything together?
Yep. Fact, we should probably stop right there.
Yeah, I
Okay.
thought that slide was actually. a
Yeah,
good place
I
to-
mean, so, I mean, yeah, I'll wrap my portion up. I mean, the bottom line is the technology works. It works unbelievably well. It's very easy. You don't have to buy a lot of capital equipment for your office. If you're working with a lab that you're really happy with their aesthetics, you get to keep them. We offer the technology to make the fit great. These guys have the artistry to make the look great. And you're left with a wonderful prosthesis. Okay? And again, it can be both immediates and finals. Thank you.
Thank you.
Yeah, just one question here, and then can you send the immediate provisional file for us to print in our office for a temp, or you prefer to control this and print yourself? If so, turnaround time.
What was that? There you go. The answer is yes.
The
You
answer
can
is
have
yes,
it if
and
you have
that
your
was
own
on the
printer.
lab side, and I think that's everything on here.
The
Any
Trian or
other?
the provisional? It was a question about the provisional?
Yes.
The Trian can work the same way too. You can get the STL file and print your own Trian, if that saves you some time. Cool.
All right, so
Thanks, guys.
I'll switch over to Dr. Scott DeRossi if anyone has questions while we're doing the switch over.
Well, I'm gonna stay, so if any questions come up,
Absolutely.
you know, it's all good.
Okay, Dr. DeRossi, give me 1 second here. I'll take the lavalier, the mic from you. Right? The only thing we were worried about.
I know, and I almost did it.
And then Dr. DeRossi, can you hear me okay?
I can.
Okay, let me make sure everybody here can hear you okay.
That
And
would be good.
I could possibly change your view too, so you're not looking at the wall here. But hold on 1 second. No, I'm just getting the text set up. And I gotta turn up the volume.
Here's the volume that has the facial cutbacks.
All right, Dr. DeRossi, do you mind speaking for a minute, just so we can?
Yeah, is this okay? Is that reasonable volume?
Okay, yes.
Okay.
Let me make sure the display kicks in, so hold on. Hold on 1 second. We're not seeing your screen, so hold on a second here. Okay, can you try to share screen again?
Yep. Let's see.
It looks like it's loading. Okay. I have it in presenter view. Perfect.
There we go. There we go.
All right, give me a minute. I'm gonna have to make it larger for those that are here in person.
Okay.
Okay. And then I'm just gonna bring everybody together here. Is everything good on your side, Dr. DeRossi?
I do believe, yeah.
Awesome. All right, so. Seem like you're talking to yourself. Here's some people. All right. All right, Dr. DeRossi, we are ready for you to take over and talk to us and our virtual audience as well about Nexus Dental Systems.
All right, great. Thank you, Ann. Appreciate it. Appreciate the invitation, and hopefully we'll be relatively quick and efficient with our time and try to have more time for some conversation and some questions. So basically what I want to talk about is just how we can master medical billing for what we're referring to as medically necessary oral care and surgery for a number of different reasons. Number one, to improve access for patients. Number two, to advance medical dental integration. Number three, to drive and grow patient volume in our practices. And number four, to increase revenue. Many people think about medical billing and sort of understand the challenges and nuances associated with it, and a lot of times there's a significant amount of fear about pursuing medical billing for oral and maxillofacial procedures and surgical procedures. But the reality is it's easy to do if we understand the language, the coding, the nuances, and the like. So what I wanted to do is just talk about Nexus Bill, which is our complete solution that does both commercial and federal billing, and sort of introduce you to the idea of medical coverage for implant surgeries, talk about accurate coding and documentation and how we can move towards that direction, what billing we can do for specific services, talk about a little bit about compliance, efficiency, and claims processing, the importance of interdisciplinary and interprofessional collaboration for billing success, and then really introducing you to Nexus Bill. So we define medically necessary oral care and medically necessary surgery as sort of two similar but distinct areas. Medically necessary oral care would be medical billing for temporomandibular disorders, facial pain, biopsies, things of that nature, obstructive sleep apnea. Where medically necessary oral surgery is really about getting reimbursed by Medicare and the federal agency of Medicare for those over the age of 65 that are Medicare eligible, and or commercial insurances for the surgery necessary to do implants. So think about the all-on-X surgeries and the jaw and bone grafting that leads to that. It's important to understand, though, that Medicare, as we know, doesn't routinely cover dental procedures, right? So cleanings, fillings, extractions. However, it does cover medically necessary oral treatments. And there are some dental exclusions that have existed now for a year or so. We know clinicians are getting reimbursed for oral complications of cancer therapy, temporomandibular disorders, oral appliances for obstructive sleep apnea, pre-surgical evaluations for organ transplant and cardiac procedures. And there have long been clinicians. I'm an oral medicine clinician by training, dental school at UPenn, oral medicine residency at UPenn, and was there on faculty for many, many years, and have only billed medical insurance, both federal and commercial, have only used CPT codes and ICD-9 and 10 codes, and have never billed a dental code in my life, mostly because my practice was in orofacial pain and TMD, mucosal lesions, salivary gland disease, and dental sleep medicine. But what we have found is that Medicare will cover surgical treatments in preparation for and part of implant retained and supported prostheses. And that's really where Nexus Bill comes in. So this is sort of the world that I lived in as it relates to oral medicine coverage. And again, been doing this since 1997, only billing medical. What you may or may not know is that there are obviously different parts of Medicare, and each cover different aspects of healthcare. So Medicare Part A is hospital coverage. Medicare Part B is the medical insurance that covers outpatient services, including certain oral treatments tied to systemic conditions. Medicare Part C is Medicare Advantage, and we're getting reimbursed for Medicare with Medicare Advantage as well for some of these implant surgeries. And Medicare Part D, which is prescription drug coverage. The terminology may be new and foreign to some of us. You may hear things like PTANs, which is the Provider Transaction Access Number, or people refer to CMS, which is the Center for Medicaid and Medicare Services. We talk about ICD-10 codes, which is the diagnostic coding system that's used in medicine. CPT codes are used instead of CDT codes. There are clearinghouse claim scrubbing issues. There's Change Healthcare. All these different sort of terms and agencies and regulatory bodies play a role, including in claim adjudication with Medicare administrative contractors and their fee schedule, which is MAC. And those vary across different regions. And I'll actually show you some of the numbers actually from the New Jersey and Philadelphia area. So in order to become a Medicare provider and to bill Medicare, we have to enroll as such using PCOS, okay? And we have a couple of enrollment options. One is to be a participating provider that basically accepts Medicare approved fees and assignments, and then a non-participating provider, which individuals can charge about 115% of Medicare's allowable rate, but has to bill the patients directly. There are some specialists that choose an opt-out status, meaning that they don't bill Medicare and instead enter private payment agreements with Medicare payments with patients. So, you know, you may be asking, why the heck would I ever want to go down the road of enrolling in Medicare and billing Medicare for implant surgeries? And we'll talk about that in a little bit, but I wanted to set the stage around our process and what that looks like at a 30,000-foot view. So the way Nexus Bill works is it's Medicare verification, eligibility, and coverage, working with the clinician to determine medical necessity and making sure there's proper documentation using our software, selecting appropriate ICD-10 and CPT codes, which the software does for you, claim submission with that supporting documentation, and then handling claim denials and appeals. All of that happens under the Nexus Bill process. This slide is very detailed, but what it does do is it does demonstrate that there are differences between medical billing in the federal space and medical billing in the commercial space. The bottom line is billing Medicare is easier because it's one consistent, identical process throughout versus the commercial side where there may be different rules in terms of coding, claim transmission, reimbursement basis, appeals processes, audit authorities on the commercial payer side. So Blue Cross may function differently than Aetna, which may function differently than United Healthcare. And so it becomes very, very challenging to work in the commercial space because of that variability. But what we do know is that in order for this process to be successful, there's a lot of learning that needs to go on if you want to do it on your own without a trusted partner like Nexus Dental Systems or a software system like Nexus Bill. You have to understand ICD-10 codes and how to use them, linking them to CPT procedural codes, making sure that we're using documentation best practices with our clinical notes, linking the oral health condition that we're diagnosing and treating to systemic conditions and comorbidities with appropriate x-rays and pathology reports and lab results and medical referral letters. And something that in 28 years of teaching in dental schools, I know we teach it, but then people go out and they become really bad and poor note writers. And so it requires a properly structured history and physical examination in the form of a SOAP note, which, again, our software does as opposed to a traditional handwritten or an electronically crafted note from A to Z. So again, if you're trying to do this individually or as an individual practice, there becomes an increased burden on the clinician and the staff to be appropriately trained and up to date, to make sure that they are getting the necessary pre-authorizations, submitting the claims electronically, tracking them, using the appropriate clearinghouses, making sure the ICD-10 and CPT code combinations are accurate, making sure that the documentation is thorough and supports medical necessity, and that people in the office are staying updated on Medicare policies through CMS guidelines and MAC updates. And again, then there's always the risk of denials, and whether it be documentation or pre-auth issues or failure to demonstrate medical necessity, we know that it could be related to not using the right forms or tracking claims and following them up in a timely manner, or utilizing clearinghouses not to the level that they need to be used to improve claim tracking, and then having an understanding of the appeals process so that people within the office know understanding Medicare redetermination requests and strategies for effective appeals. It becomes burdensome for an individual practice or group of practices to take this on, which is why it becomes important to have the right partner like Nexus Dental Systems and the right software to make this seamless, to make it predictable, and to make it legal and defensible. And so that's really sort of where we come in and how Nexus Bill works. We auto-generate the correct ICD-10 codes and CPT codes. We craft, using AI and your notes, a clinical narrative that is medically appropriate and is compliant with medical billing, and creates those medical justifications and links of comorbidities to adverse oral sequela. So it really is a seamless solution for your team. It's automated. It's how we drive compliance because we have pre-built workflows. We have smart documentation prompts. We have claim tracking. And all of this is, in essence, offloaded from the office staff and the dentist and the professional, the clinician, to make sure that this is done in a very systematic way with people that have been doing it a long time. So why is this important? Well, I mentioned patient access, and we'll talk about that. More and more people are getting older, and the over 65 age group is the fastest growing segment of the population. They're maintaining their dentition longer, but they still have needs for tooth replacement. We know we're seeing advancing medical and dental health integration. And so what happens is patients that maybe historically have not been able to afford an all-on X treatment because the overall out-of-pocket cost was too much, now are saying yes to this because a portion of the surgery leading up to that procedure and outcome is covered under Medicare. And so there's increased case acceptance. There's improved patient outcomes on the medical side and overall health side. It allows for practices and DSOs to have a revenue cycle differentiator, and it allows for robust incremental growth in patient volume and in revenue. So again, I mentioned just the numbers of people. Right now, there are 65 million Americans over the age of 65. It's going to be 80 million in 5 years. As of right now, or last year, almost 70 million Americans without dental insurance. 40% say they have limited or will have limited oral care due to their financial situation. 80% of patients know that they're delaying oral treatment will cost more money over time. But also that a majority of patients and a majority of oral health clinicians and dentists across the United States are unaware of the medical benefits for oral surgery procedures. By oral surgery procedures, I'm talking about implant and jaw bone augmentation and grafting procedures is there. But the connection has to be between what's going on in their oral cavity and the comorbidities that they have. Well, 45 million Medicare age patients have chronic illnesses, 80% with at least one, and 68% with two or more chronic conditions that are directly affecting their oral health. So these edentulous patients are at higher risk for advancing and increased medical costs and morbidity. morbidity. So this becomes an opportunity for us as oral health professionals to make a difference. So who are we? What do we do? Nexus Dental Systems has been around for about 13 years doing medical billing. We have over 1,000 users of our Nexus Bill software. They're not all oral surgeons. In fact, a majority of them are not. Most of them are GPs, super GPs that do their own surgical implant placement. Anyone who's involved in implant rehabilitation surgeries, clinicians who do dental sleep medicine, oral medicine, oral pathology, temporomandibular disorders are using this software. What we do is fully credential the clinician and the practice with audit protection. On the implant side, we've been seeing reliable and predictable results, basically achieving consistent reimbursements of about $7,500 to $15,000 per case, depending if it's one arch or two arch through the appropriate medical necessity documentation. We have a Nexus billing portal, which simplifies documentation, billing workflows, reduces errors, makes submitting and tracking claims easy so people in the office don't have to worry about it. We have audit preparedness and protection built into the system and an audit defense team. We have comprehensive training and support with step-by-step training for staff and the clinicians, the dentists, with proper documentation and billing workflows. And there's a high return on investment, and I can share what that looks like. So just at a 30,000-foot view, I mean, basically there are sort of three phases to Nexus Bill. One is establishing the payer landscape for the clinician, the offices or groups of offices that we're working with, making sure everyone in there knows the process. And I use the word paperwork, even though it's completely digital, learning the appropriate terminology. Again, it's learning a new language. It's like moving from speaking French to speaking Russian. They're both okay, but you can't speak French to a person that only speaks Russian. And that's really the difference between the dental language encoding and the medical language encoding. We have an opportunity to work with the practices to build claims experience and a claim history, build an understanding of who pays out of network and who needs in-network access. We use under office NPI numbers. We have network activation that can be used. We can bill using our contracted rates. We have in-network with major payers and plans. We've demonstrated increased approvals. We have medical directors in all 50 states. We have compliance oversight and continued team coaching to optimize medical reimbursement. So, so what does this mean when a patient's in the chair? And that's, how is it going to disrupt my day-to-day operations with a patient that I'm working up for implant surgery or an all-on-X? The answer is it doesn't. The screening, the intake, the consultation, the treatment plan all happen like it normally would. However, that consultation and that exam, we have a parallel system that is medical compliant, history and physical examination documentation that needs to be completed, which would then create a customized letter of medical necessity with a customized treatment plan, appropriate ICD-10 codes linking to the appropriate treatment surgical codes, which would be CPT codes. And again, this would then be, after the surgeries, billed to Medicare and reimbursed. So how does this benefit us as clinicians and as the patients? Well, it's standardized, patent pending medical billing software for dentistry. We have proprietary end-to-end workflows and documentation that is all built into the system. We have seamless, comprehensive integration, training, and support for clinicians and staff. Offices are able to, in real time, track claim status. We have streamlined communication with various payers, both on the commercial and on the federal side. We've reduced claim denials and delays, and we've validated support in audit and in the clawback process. And so if you're not familiar with sort of the difference between how the feds work, the CMS works, and commercial insurance, basically, if you're doing a procedure with Blue Cross and Blue Shield, there's a pre-authorization process that needs to happen for reimbursement. And sort of you have to go through the mindset of, and this may be a little austere, but guilty until proven innocent. Where on the Medicare side, you don't have to go through that process, and you are innocent until proven guilty. So as long as you've demonstrated medical necessity and your coding and documentation is appropriate, it is well within the rules of CMS. However, CMS does occasionally review their payments out to clinicians and will occasionally claw back a certain amount of dollars. We have built in a clawback defense, and I can talk about what that is. But I wanted to give you this is a practice that when we instituted Nexus Bill in this practice, they had two clinicians, and they were doing about $3.5 million in sort of regular. Neither of them are prosthodontists. They're both super GPs and did implants. What we did with them is we started to work with them and use Nexus Bill. They started with their Medicare reimbursements and got paid about 14 days from claim submission. We didn't have to go through pre-author denial process, right? Because it's Medicare, not commercial. We've had 98% success on our audits and clawbacks. What's been interesting is we've been able to track case conversion, and we're seeing 30 to 65%. In this office, it was this particular office that I'm talking about, it was closer to 65% case conversion with a 50% implant unit growth, a 200% growth on all-on-4s, 103% growth on locator fixed growth, and a 325% on overdenture growth. Again, because more patients are getting to yes, because now they're getting a certain portion of their overall global treatment covered by Medicare. And I had mentioned that these MACs by region, and this is just a for instance of New Jersey. We have these all in an Excel spreadsheet, so you can see New Jersey state. Like if we're doing a 21127, which is a jawbone surgery, bone graft, lower jaw, the MCR fee schedule payment is $43.87. Medicare is paying about $21.93. So again, is this as good as someone coming in and paying cash? No. However, it's better than a patient saying, I can't afford this at all, and I'm walking out the door and not doing this at all. And that's really the target audience, as we're seeing more and more patients over the age of 65 who don't have the financial means to do this. This gets them to yes more quickly. So what we do is training and onboarding, credentialing for the clinician. We have expert customer success specialists that will work with your team and you. We have a coding team. We have a billing and claims team. We have medical directors, as I mentioned, physicians in all 50 states, and we have a compliant and audit response team. So brass tacks. This has changed a little bit, and so I apologize if perhaps if you get online and look at this and it's a little differently than what I'm presenting. But there's an initial investment, and sort of how this works is subscription service. There's a credentialing one-time cost. There's a training one-time cost and a software fee, which is recurring annually. The billing services is 22% of revenue. It seems high. It's actually 17% of revenue, and 5% of the revenue goes into escrow as audit defense in the case of clawback. The estimated revenue per arch, based on our experience, is about $7,500. Doing cases 12 a month, the monthly revenue production on that would be 90,000. The annual revenue production would be over $1 million. And so if you look at $1 million times 22%, you'd be paying about 38,000 plus the $2,400 software fee to get that. Now, let's look at the profit analysis. 1 million in annual gross profit before the investment of 2,400 is 840,000. And then if you look at first year net profit after the initial investment, it's about 826. So when you calculate the return on the investment with net profit over initial investment, you're looking at a significant 5,200% ROI. So the initial investment and the monthly net profit, taking that into consideration, that break-even point is about a quarter of a month. So within 2 weeks, 1 week to 2 weeks, practices are breaking even because of the increased volume that they're seeing. So if you want to learn more, there's a QR code that you can scan. There's also contact information for what we do. I'm Scott DeRossi. I'm our Chief Strategy Officer at Nexus and Serendipity Partners. But I'm happy to share this potential opportunity to increase your revenue and increase patient access with your implant patients.
Scott, can you display your QR code again?
Oh yeah, sorry.
Sorry, we were all in the midst of snagging it.
Yeah, let me.
And
I got
then,
a little overzealous, didn't I?
no worries. We appreciate the efficiency. Yeah, I think everybody's just digesting right now, Dr. DeRossi.
It's a lot. It is definitely a lot. And again, the goal wasn't necessarily to convince you all to do this. It's just to let you know that this is available. It's certainly something that's growing, and the patient population that is going to need the implant supported prostheses that we're talking about are the ones that are growing at the fastest rate and have Medicare as their primary medical insurance. And so again, this is something that may be worthwhile to think about now. It may be, we've had individuals, honestly, that said, I don't want to do this in my practice. I have enough patients that are paying for this right now. I don't need to do more. What's interesting was we've also had practices who have taken this on where the more senior person has not done it, but the more junior person, an associate, has done it. And we've actually compared the growth of their practice. It's amazing how many people of Medicare age, once they realize in a community that there's a clinician that is taking Medicare and helping, and that's helping fund their implant surgeries, that they are becoming quite productive and outproducing their senior partner.
have a
And can you hear me okay?
Yeah, Dr. Corral, we can. And then we have a question from Dr. Turner too, but go ahead, Dr. Corral.
So my question was in the beginning, you wrote like 4 or 5 reasons of why what would be the main causes to pay for medical. So what I'm understanding is that we're trying to make our cases fit into those 4 or 5 reasons. Is that correct?
No. Those are the ones that are currently part of the dental exclusion right now. So any dentist without appropriate documentation or anything else can bill for those 4 domains. Medicare has approved those irrespective of anything. What we're talking about is doing surgical procedures and linking those surgical procedures to comorbidities which all of these patients have, right? They have cardiovascular disease, they have osteoporosis, they have diabetes. That's what we're talking. So it's totally different. We're not,
Understood. Okay, I
yeah,
get
we're
that
not
now.
putting that. That's the stuff that's existing and approved and
Understood.
has been. Yeah.
So what is the percentage that this happens, that I get a patient that comes in for a consult? I tell them this is kind of how much you can expect to get off from
Yeah.
Medicare. I do the procedure because it's not commercial insurance, it's
Yep.
federal. And
Yep.
and what is the percentage that comes through versus that I'm stuck holding the bag?
98%.
So your software, your notes, everything
Yep.
that you've got is going to
Yep.
get me to 98%.
Yep.
Okay.
Yeah. Yeah, I mean the feds. The reality is Medicare pays. It's certainly more predictable than commercial insurance, where you have to jump through a bunch of hoops. And that's why I said, going down the commercial road is much trickier. And again, a lot of people think about, well, I don't want to do this because I'm afraid of fraud and going to jail. There are people who've been billing. There are dentists with no MD who have been billing Medicare for a long, long, long time. I mean, I've been doing it since 1996. And again, it's all about demonstrating that medical necessity, linking it to the oral issues that you're treating, having the appropriate documentation, using the right codes, etc. So there's a process. Now, the advantage of this is it takes all of that thinking away from the dentist who's not used to speaking that language, right?
Sure.
You can still speak French. We're translating it into Russian and we're submitting it to Medicare in the language that they understand.
So tell me a little bit about the 5% for audit defense and what happens there and what happens if we exhaust those funds.
Yeah. So
Tell me a
no, it's a
little
good,
there.
yeah, good question. So the 22%, some people can opt out. So we've had some clients who have said, listen, I'm just going to pay the 17%. And if there's a clawback, there's a clawback. I have been subject to a clawback just, and it's one of those things. Medicare just randomly does audits. They look at it. They sample 10, 20, 30 charts. They look if things were overcoded, undercoded. They make a judgment and they say, you know what, we think we've overpaid. We want $5,000 back or $10,000 back or whatever. So what we've done in order to sort of soften that risk is allow customers to say, listen, I'm going to pay the 22%. That 5% stays in essence, an escrow fund. And if there is a clawback, we pay it. You guys, it's not paid by the customer. It's paid by us because we're the ones doing the medical billing.
Even if it exhausts my funds of that 5%.
Correct.
Okay.
Yeah, and again, Medicare only claws back up to 3 years retro. So they'll only look after 3 years, sort of past the statute of limitations on a clawback. So they can only go back, or right now only go back 3 years.
What does it look like to the feds though, when you're a provider and you go from billing $0 and I've got the infrastructure in my office to bill, $6 million? I mean, that's got to throw up red flags. So, I mean, we're banking on you, right?
Yeah, I mean, you're not doing it. We are. You're doing the surgeries. We're doing the billing. Yes, we're using the office NPI, but we're using the clearinghouse, so they're getting a lot of the spotlight is not being shown on you as the individual because you're just. I don't mean this to sound disrespectful, but you're just one fish in a bigger pond of fish swimming along. So again, there's strength in numbers in that regard. That's another sort of byproduct of the system and a positive in terms of risk mitigation to the individual clinician in office.
So the NPI is tied to you and I'm the small fish beneath you.
Hey, that was a terrible analogy. My
No,
apologies.
it's true though. It's important. It's important distinction.
Yeah, I mean the risk is on us, not on on the clinician. Again, we've been doing this for 13 years. And part of the reason for those of you who don't know me, I mentioned I went to Penn dental school and oral medicine. I then moved to the Medical College of Georgia as a department chair, and all of our staff, our faculty did billing. We had pathologists, we had radiologists, all doing medical billing and credentialed on Medicare. And then I became the dean of the dental school at UNC Chapel Hill. Did that for 5 years, and then I had the opportunity to be a founding dean for New School. So when I decided to leave academics, I was obviously very careful in what organization I joined, and I would not have joined an organization that I felt was going to do any risk to me, to other clinicians, their reputation, or to patients. So I firmly stand by what we're doing as being legal, defensible, predictable, and actually the right thing to do by patients who can access care and access this benefit when they historically haven't been able to do it.
Dr. Turner, was your question answered in that?
We won't have one or two questions. We'll have a plethora of questions. So my question is who, when we contact, my office manager just did the scan up there. We're very interested in moving in this direction. I see great promise in it. Who exactly will she be talking to when she contacts your Nexus Dental Systems?
Scott,
Yeah.
could you do that?
Yep. So who will she be contacting at this number? It will be the head of our medical billing program, probably Summer Terry. But I mean, I am obviously willing to share my contact info as well, and if people want to reach out to me. But we don't have a sales team, so to speak, which is why I'm talking. I'm a terrible salesperson. But we do have experts that you'd be talking with that would walk you through the process. So Summer Terry would be talking with the billing or office manager in the office. John Poovey, who is our chief dental officer, will be talking to the lead dentist in the practice. And so there's one-on-one connections from the very beginning when we do enrollment to training to launch to monthly check-ins.
Thank you very much.
Yep.
Any other questions? Either virtually or in person for Dr. DeRossi or for Vince? Or for anybody? Any parting last words there, Dr. DeRossi?
No, I just encourage people to think about it, think about the changing demographics of disease, the changing demographics of age, and the opportunity to, do more for ourselves and our practices, but also do more for our patients. And I think this is a step in the right direction in terms of oral and medical integration and improving overall health. So I appreciate your time today, everyone, and I appreciate the invitation. And again, my apologies for not being able to get up there in person. And I am so thankful that you allowed me to do it this way.
Sure, and in the next 10 minutes after we sign off, if there are questions, are you okay with me calling your cell and helping?
Yeah, of course, absolutely. Yeah.
Awesome. All right, Jay, did you want to come up for a second here? And,
Just real quick, thank you guys, everyone, for coming out. We really appreciate it.
do you mind standing in front of the camera? Sorry.
I gotta stand in front of Tiny. Guys, thank you for jumping on remotely. Thank you guys for coming in person. We're always trying to find different things to present. It's not just the same thing over and over again. And hopefully you guys find this very interesting. And Ann has a lot of great stuff coming out on all the social media stuff for more follow-up stuff. So just don't hesitate to call any one of ourselves if you need anything.
And if you need anybody from the dental lab side to help facilitate either Nexus, communications, we can be the liaison between that as well. Yeah, we know how to connect with them directly.
I mean, one of my questions, Ann, though, is did you pick 2 Nexus organizations on purpose? It just makes it easier for printing and maybe.
I actually would like Jay he has a very good answer for that, Scott.
I mean, do you just go through the alphabet and we're on the ends now?
In all actuality, all honesty, no. It's just I know both solutions are very, very play very well nice in the sandbox together, because the two most common things I talk about all nights with my clinicians is, one, how do I get more patients in the chair, you know, and get more case acceptance, and two, how do I make it faster so I have more, you know,
Yep.
more problems.
Yep.
So these exactly.
Both, and yeah, and but I agree, both presentations answer those two challenges quite well.
Very
It
simple
wasn't
solutions.
the marketing side of it that made it easier for us. It
Nice
was,
alliteration here.
yeah, we consistently get asked questions on how to help patients in the chair and see less chair time. So Jay and I are constantly trying to figure out ways to make all that happen. So
All right.
that's where we are.
All right, thank you guys. God-
Thank you,
God
Dr.
bless. Have a
Grassi.
good night.
My pleasure. Thank you.
Dr. Bolchi, thank you, Dr. Corral. Thank you, Andrew.
Thank you. Thank you.